Hello, everyone. Thank you so much for being here. We're so excited to bring this topic to you today. More folks might join us as we get started, but I want to kick off and share a little bit about what we're going to be discussing today. So thank you for being here as we discuss infant and early childhood mental health. We are going to be hearing a lot of different perspectives today, a lot of information about what infant early childhood mental health is. We're really going to work to understand the importance of this topic and to reduce accessibility barriers in Ohio. One thing off the top I want to mention, we're talking about infant and early childhood mental health, and you may hear us refer to this in long form or IECMH. I'm Caitlin Feesby Feldman. I am the Ohio Infant Toddler Court Team and Policy Coordinator, and I will be facilitating our webinar today. Before we begin, just a few housekeeping things so you're all aware. This webinar will be recorded. Closed captioning is available. All participants are encouraged to stay muted, but we do encourage you to enter any questions that you may have in the Q&A feature, as the chat feature has been disabled for this webinar. We do have a full agenda, so if we can't get to your question during the event, we will certainly follow up afterward to provide, if you provide your email address with the question. We want to make sure that we're able to answer that if you do have something that we can't get to during the webinar. And finally, all participants will get a recording of this webinar along with copies of materials mentioned after the event is concluded. I want to share a little bit about Groundwork Ohio before we dig into our discussion today. Our mission is, Groundwork Ohio is a committed, nonpartisan public policy, research, and advocacy organization formed in 2004, so this is our 20-year anniversary. We champion high-quality early learning and healthy development strategies from the prenatal period to age 5 that lay a strong foundation for Ohio kids, families, and communities. We at Groundwork advance equality early childhood systems in Ohio by engaging, educating, and mobilizing diverse stakeholders and strategic partners to promote data-driven and evidence-based early childhood policies. Please feel free to follow Groundwork Ohio on all social media platforms. We are found on all of these listed here. We also have a newsletter that comes out weekly, and it is a great way to stay apprised as to what we're working on behind the scenes and all of the hard work that our amazing team is doing every single day on behalf of Ohio's youngest. This is an overview of our agenda for today. For each panelist, I'll begin by reading their names and bios, and then we'll hear from each panelist with a brief presentation in the order listed on the screen. I will then facilitate a discussion among our panelists. And again, please feel free to include anything in the Q&A function that you would like to have answered as we're going along today. Quickly, I would like to plug some upcoming events that are going on throughout the state. Groundwork Ohio is going on the road for our roadshow listening tour. So we are holding community conversations throughout Ohio to engage families, early childhood professionals, maternal health experts, local government officials, and statewide policymakers about how the challenges facing our state's youngest can be addressed. We really want to hear from individuals at local, community, and state levels, and we hope that you'll consider joining us for an upcoming event near you so that we can hear from your unique perspective. What is working in your community? How can we make Ohio the best place to be a young child? To learn more, you can go to this website, www.groundworkohio.org/roadshow, to see where we will be coming at a location near you. In honor of Mental Health Awareness Month and in observance of Children's Mental Health Awareness Week, I am thrilled to facilitate this webinar centering around infant and early childhood mental health. This is an important topic because there tends to be a misunderstanding of what IECMH is, why it's important, who needs IECMH care, It is my great privilege to collaborate with three brilliant and highly skilled panelists today who will utilize the rest of our time to address these very topics and more. Our first speaker is Dr. Alex Bacido. Dr. Bacido is a senior technical assistant specialist at 0 to 3, where they work with the infant and early childhood mental health team. In this role, they guide states in building sustainable systems that meet the unique needs of infants, young children, and their families. Dr. Bacido formerly served as the SRCD State Postdoctoral Fellow at the Rhode Island Department of Health, where they work to expand access to early childhood and family support services for historically underserved communities. This work included leading a successful initiative to secure and roll out Medicaid funding for evidence-based family home visiting. Dr. Bacido completed their clinical internship at Brown Medical School and received their PhD in child clinical psychology from the Pennsylvania State University. As a graduate student, Dr. Bacido was a Doris Duke Fellow for the Promotion of Child Wellbeing and a National Science Foundation Graduate Research Fellow. Dr. Bacido also spent nearly 10 years as a community mental health clinician, working primarily with trauma-exposed children and caregivers. Dr. Bacido is dedicated to working at the intersection of research and policy to target sources of intergenerational disadvantage and enhance child well-being. Dr. Bacido, thank you so much for being here, and I will turn the floor over to you.
Thanks for that introduction, Caitlin. I appreciate it. Good morning, everyone. I'm so excited to be here with you all to talk about infant and early childhood mental health and why it matters so much. I'll give a brief overview here during this more formal presentation, and then look forward to digging into some more specifics during the panel section later in this webinar. So next slide. So what is infant and early childhood mental health, or IECMH? So IECMH, which I will, I think, mostly refer to it as during this presentation, is the developing capacity of the child from birth through 5 years old to form close and secure adult and peer relationships, experience, manage, and express a full range of emotions, and explore the environment and learn. Two important notes here. One, which will probably be obvious to many of you, is that those three capacities are going to look very different depending on the age. So a close and secure adult relationship at 6 months of age is going to look very different to a close and secure adult relationship at 4 months of age. That kind of developmental difference will be a touch point as we go through and talk about different aspects of the infant and early childhood mental health system. The second, which I want to point out as well, is that last piece on the bottom of the slide, which is that infants and young children are different from older kids and adolescents, and certainly from adults, in that they are so embedded in their families and communities. So every time we think about an infant or a young child, we also have to think about what does their family look like. And we talk about that as looking at the whole child, because the whole child, like at that age, the child really also includes their closest caregivers. And because of that, those three capacities are also going to look different depending on the family, depending on the culture in which the family is embedded. So the way that a child expresses emotions healthily may look different from family to family, may look different depending on what country grew up, their most frequently spoken language, and other aspects of their culture. And that, again, is important to kind of keep in mind as we move forward and talk about infant and early childhood mental health. Next slide, please. So why are we talking specifically about the first 5 years? Well, it's what clinical and developmental scientists call a sensitive period, which is basically a time in development where the brain and body are really open to outside influence. So in this case, in the first 5 years, we know that the brain and the autonomic nervous system, which plays a really important role in the development and expression of emotions and attention and in social relationships, those systems are developing really rapidly. In fact, more rapidly than at any other point during the lifespan. And because of that development, they're more sensitive to input, both the good and the bad, than at any other time in life. Next slide. So that means that supportive experiences in the first few years of life really have the opportunity to promote healthy development and the development of all those 3 capacities that we saw on the first slide. However, problems with development, so stressors like caregiving stress, experience of trauma, poverty, can kind of disrupt the development of those systems. And we know that infants and young children can and do experience mental health problems. In fact, between 10 and 16% of infants and young children experience a diagnosable mental health condition like PTSD, anxiety, and depression. And that when there are significant stressors, whether it's substance use or parent mental health, certainly trauma, certainly poverty, the risk of infants and young children experiencing mental health problems increases rapidly. You see that 22% there. So for infants and young children who experience some of those stressors, the risks rise to that 22%. So early childhood does offer a unique opportunity to promote strong mental health from the beginning, but when babies don't receive adequate emotional support, or just when parents are doing the best that they can and there are more external stressors, infants and young children do experience diagnosable mental health disorders. Next slide, please. Thank you. So why does it matter so much? And I think we'll talk about this a little bit more later. But in short, if left untreated, infant and early childhood mental health disorders can really have a detrimental effect on every aspect of child's development, because infant and early childhood mental health is the foundation for all future development. So think of it, if you don't develop a strong foundation, a strong ability to feel and express emotions, the ability to connect with peers and adults, it's going to be really difficult to build on those competencies later. So unsurprising to those of us who know the research, but children with who have a mental health disorder during infancy or early childhood actually more likely than their typically developing peers to grow up to have internalizing disorders like depression or anxiety, things like behavior problems and criminal legal system involvement. They've been shown to have lower educational attainment and future relationship difficulties. So it's not just that we don't want to see infants and young children suffering. It's that when there is not a strong foundation on which to build all of the competencies that kids and adolescents develop, we see later development impacted as well. Next slide. So it's clear that what happens in the first 5 years of life matters, not just for childhood, but beyond. So how can we support infant and early childhood mental health? The good news is that there is a whole continuum of services that are evidence-based that we know support families and young children in being as healthy and happy as possible. So what you see here on this slide is this continuum. And it's really how we talk about the different services that families and infants might need at different points through development. So promotion really refers to kind of supporting the emotional well-being of all children and families. So it might involve programs to educate parents, connect parents with services, talk about what kind of parenting supports healthy social and emotional development, and teaching them about the role they play in creating this responsive and nurturing caregiving environment for young children. Then prevention is the next level. So prevention approaches, which include things like infant and early childhood mental health consultation in daycares or in pediatric offices, can help identify and support children who are at risk of developing mental health problems. So maybe these kiddos are not showing signs of a mental health disorder in this moment, but we know that they have those stressors that I showed earlier in the presentation. And so they might be at risk. And so we might offer them services like screening and support aimed at either addressing the situations that are causing the risk or offering parents more support kind of to bolster the family and bolster their ability to provide kind of the safe, sensitive environment that we know supports good mental health. So the next piece is assessment and diagnosis, which I'm going to talk about a little bit more later. So for now, I'll just say the DC 0 to 5 is really the only way to assess and accurately diagnose a kid under the age of 5. Usually assessment and diagnosis should take place over a minimum of 3 to 5 visits and over a period of several weeks, because unlike with adolescents or with adults, we are not just taking a list, we're just not able to ask kids about a list of symptoms. We are assessing the whole child, which includes, yes, their emotions, their behaviors, but also their family, their context. And so to get a really accurate picture of who this kiddo is, what they need, the DC 0 to 5 structures the assessment to take place over a long period of time. And it's important to note, and I think probably we'll talk about this later, we don't diagnose the child, we diagnose the condition. So the symptoms are a sign of what types of support a kid and a family might need. It is not, the diagnosis is not who that child is. What the diagnosis can do is show a clinician what kind of evidence-based treatment that infant, toddler, and family needs. So probably many of you know that there are evidence-based mental health treatments for infants and young children. It does not look like an infant coming in and sitting on a couch and talking to a therapist. That is not the kind of treatment we're talking about. Most evidence-based treatments for infants and young children are dyadic, meaning they include at least a primary caregiver, if not the entire family. And there are a whole host of evidence-based dyadic services for infants and their families. And so that would be the final step in the continuum when a child is already exhibiting some mental health symptoms. Next slide. And Caitlin, I don't know how we are on time, but I can skip this because we'll get to some of this a little bit later if you want to move on to someone else.
Thank you so much, Dr. Pacito. That was really a great way to level set everyone's understanding today of what IECMH is, and really appreciate you bringing your expertise to share that with us. Thank you. Our second speaker is Twinkle French-Shockey. Twinkle is a dynamic force in the realm of infant and child well-being. As the co-founder and director of Moms to Be with the Ohio State University Wexner Medical Center, Twinkle spearheaded a groundbreaking community-based education program Focused on empowering pregnant moms for healthier babies, the initiative expanded its impact from Central Ohio to Dayton, addressing areas with the highest rates of infant mortality. With a wealth of experience spanning 2 decades at Nationwide Children's Hospital, Twinkle played diverse roles championing the welfare of babies and young children in the community. Armed with a master's degree in early childhood special education and a certificate in infant mental health, she brings a specialized skill set to the table. Twinkle's influence extends beyond borders as she served as a consultant for 0 to 3 with military projects. Her expertise shines as she conducted trainings at military bases nationwide, enlightening professionals on the effects of deployment, grief, loss, trauma, injury, and the reunification for infants and young children. A trailblazer in the field, Twinkle holds the title of past president of the Association of Infant Mental Health in Ohio, or AIMHI Ohio. Her commitment is further reflected in her active participation on the governor's Early Childhood Advisory Council and the Groundwork Ohio Advisory Board. Passionate about growing infant mental health in Ohio, Twinkle envisions a future where every newborn is welcomed into the world and finds a nurturing space in someone's heart to flourish. Her journey is marked by a relentless pursuit of ensuring each child's well-being from the very start. Twinkle, thank you so much for being here, and I'm going to turn the floor over to you.
Thanks, Caitlin. Wow, that was a lot. I love the world of infant and early childhood mental health. And when I talk to you about this, I'm going to talk to you based on relationships. So as you think about what Dr. Alex talked about with diagnosis and assessment and treatment, all of these build on each other. Next slide, please. So the world of diagnosis with early childhood, people have different feelings about that. Many people feel like a child or a baby should not receive a diagnosis. Other people think, well, we have to have a diagnosis to know how to treat. And when we think about babies, we're looking at what they're doing, what they're showing us, what behaviors they're having. The younger they are, it might be regulation. It might be ability to interact. It depends on how young that child is and what we're seeing as to how to move forward. So when is the right time? And that's a really big, huge, loaded question because the right time is different for each and every family. So parents or caregivers or families are the first indicator of something might be different with the child or might be not quite typical, or they notice something. And when they bring that up to you, that's the exact time to intervene. Now, sometimes we as professionals might see it before the parents do. So we might notice something. And the goal of that is to ask gentle questions, to ask open-ended questions, to talk about, have you noticed that he's crying more than usual, or do you have trouble helping him to soothe? Those are really important questions because babies can't do this all on their own. It always takes a team of people to, when I say a team, it could be one or more, it could be one, but it's hard to regulate a baby all day, every day. And how young is too young? So that's another question. Some babies are born and they have a diagnosis. And by that, most of us are familiar with NAS, neonatal abstinence syndrome. The new verbiage for that is NOWS. So that's neonatal opiate withdrawal syndrome. That's a diagnosis that comes really early on because the mom had substance in her body and the baby might be withdrawing. And why would that be a infant mental health question? Why would you even think that that is the same as a diagnosis? It's the same because the baby exhibits lots of different behaviors that might be difficult for an adult caregiver to regulate. And so that is one example out of hundreds of examples that what we might see really early on. And why would we want to diagnose that? Because if we know, then we can do. And we're not putting a label on that child. We're not saying this baby is. We're saying the symptoms show that we need to do this. Or what could we provide for mom to help her be able to help self-regulate that baby? It's a team effort. It's a team approach. And the whole goal of this is over time. Nothing happens quickly. And I use this picture of Eva giving a vaccine to her mom because that's something that she heard about all day, every day around the time of the pandemic. And she wanted to get a vaccine and she was so excited when it was her turn. I say that because some parents want a quick fix. They really think, oh, could we get a shot or could we get some medicine or what can we do to help this baby? And that isn't how it goes with early childhood mental health. This is over time. This is practice. I use the term CPR, consistent, predictable, reliable. You have to do things time and time again to help a child find a solution, to help a family find a solution. And how or what could we put in place before we even get the diagnosis? And how important is the diagnosis to the treatment? Those are tons of really good questions. We have wait lists here. We have lots of different providers around the state, but there's more of us children who need in than there are providers to serve. And so when we think about what could we do, we have to do something. So if a mom calls and tries to get a diagnosis or tries to get in and they say, oh, there's a 6-month waiting list, that's like 5 months and 29 days too long. Because if you're asking for help today, you need something today. And what is that something? It's going to look different all around the state, but think about what would that child be eligible for? Would home visiting be appropriate? Is there a program in the area where moms could come with other moms who have concerns? Is early Head Start something that would go where we could get infant mental health assistance there? What else is in this area? Is there parenting classes? What's available now? But please don't wait. Because as you think about this, if they're telling you, then it's time to say, you know what? I don't know exactly what it is, but you're not in this alone. The thing that I'm going to say to you is please, please, please give hope. Always, always, always give hope because it's so difficult for a parent to accept that their child might not be typically developing or might have an issue or a concern. But the most important thing is to say, listen to their concerns, tell them they're not alone, and say, I'm not sure how we're going to do this, but we're going to figure this out together because people need people, especially when there's a difficulty with a child. Next slide, please. You might have heard a bit about House Bill 7. And what we're trying to do is figure out billing. And that's a really big issue. And we all do it a little differently. So I had a program and I was all grant funded. I used grant money to provide for the program, to provide for the moms I served. So I reached out to my colleagues on the board and I asked them all of these different questions about billing because that's their area of expertise. They do it all day, every day. You might hear words like ICD-10 codes or crosswalks. We already heard a bit about the diagnostic assessment DC 0 to 5. We've used the DECA IT assessment since 2001 here in Ohio, and these things are important for payment. So I'm going to try to talk through this with you about how it looks around the state. And I'm going to start with Cuyahoga County because Cuyahoga County is really on fire for infant early childhood mental health. They have figured out a way to do some billing, to get reimbursement for their services, and it's working. When I think about other areas of the state or other agencies, the billing is dependent on what the agency is able to either provide or provide for. When I talked to Dr. Chris West at Nationwide Children's, one of his biggest concerns, and Dr. Alex talked about this, the importance of having multiple visits for diagnosis. Billing through Medicaid will only allow you one visit. So you can only have one visit before you need a diagnosis. That within itself is that they pay for one visit. That is ludicrous. And I say that to you because that's not how we work with babies. That's not how we work with young children and families. We see people over time and we make change over time and we're all different over time. So when we look at what's available, what isn't available, the codes I listed on this slide were from Dr. Jane Seitz at Cincinnati Children's. So she created the TIP program. And in that program, these are some of the billing codes that they were able to reimburse for. In the adult world, there's the DSM-5, and that is a manual where professionals diagnose adults with mental health concerns. It isn't the same for children, As Dr. Alex said, the DC 0 to 5 is what we use, and that's the gold standard. And what we're looking for is the gold standard. And we're also looking for people to get paid for their work. There isn't enough professionals to help these families. And the more we could pour into evidence-based training so we can train more people, the better the world's going to be for Ohio's babies. And that's the goal here. It's just one step at a time to get closer to like a statewide vision where it doesn't matter where you are in the state, you could receive timely diagnosis by evidence-based providers that it's developmentally appropriate for that child and that family, and it doesn't happen in just one visit. Next slide, please. When I think about like the future for Ohio's babies and their families, there are many ways for us to get there. The mere fact that you're on this webinar today shows that you're interested. You're a part of the solution. And I don't expect you to solve it, but I sure expect you to jump in. And wherever you are and whatever you're doing, you have the ability to help babies and their families. For Ohio, my personal dream is to join the Alliance for Infant Mental Health. Around our country, there's 35 states and 2 countries that are already a part of that. That's the gold standard for us. It is evidence-based. It shows us that we can increase workforce development in our state by being a part of this alliance, because what it does is it creates a really high gold standard for us, for our state, for our families. And it also helps if you are outside of our state and you want to move in, because we know what trainings you have. So we would have similar trainings no matter what state or one of the countries you came from. And we know hiring in that you will be hitting the ground running, ready to go to serve our babies and their families. I would love to see trainings open to everyone. It doesn't matter your discipline. If you're OT, PT, or speech, if you are early childhood, if you're working in providing food services in one of the programs, if you're a bus driver, everyone who touches the lives of a child can make a difference. It doesn't matter about your degree. It matters that you care. And I know you're not going to solve everything for everyone, but keeping kids safe and making sure that they have a voice and that people are listening to them. We're not here to tell people what they need. We're here to listen and make sure that we can help them get to the next level. There's a place for everyone. And please, if you could do anything, share hope and never, ever, ever give up. Thank you, Caitlin.
Twinkle, thank you so much. That was really insightful, and I so appreciate you sharing your perspectives on those issues that are really important. Thank you so much for your presentation. Last but certainly not least, we have Alyssa Swiatek, who will be our final presenter for today. And Alyssa is the Associate Director of the Cuyahoga County Office of Early Childhood and Invest in Children. She is passionate about building equitable early childhood systems that amplify family voice, unlock every young child's potential, and meet the needs of all families. Alyssa received a BS in psychology from the Ohio State University, MED in clinical mental health counseling from Cleveland State University, and has worked with families and children for over 20 years. Alyssa has held multiple roles in Cuyahoga County's IECMH system for the past 18 years, providing IECMH services in the classroom and home, serving as the IECMH system coordinator for Cuyahoga County's IECMH system, and most recently providing system oversight as the IECMH program manager for Invest in Children. Alyssa, thank you so much for being here, and I'm going to turn the floor over to you.
Thank you so much, Caitlin. I really appreciate it. And thank you to Alex and Twinkle for grounding us in what infant early childhood mental health is. I'm here to give a local perspective on IECMH services and what IECMH looks like in Cuyahoga County. Next slide, please. First, just a quick overview of what Invest in Children is. We were created in 1999 through a community informed process. We are the public-private partnership focused on the prenatal to kindergarten period in Cuyahoga County. We are staffed by an awesome staff of 9 at the Office of Early Childhood, and we receive funding from both public and private sources. We have a lead agency model, meaning that we fund and administer early childhood mental health or early childhood programs, including early childhood mental health, our universal pre-kindergarten program, and multiple home visiting programs through our lead agencies. Next slide, please. Invest in Children's mission is listed here. We aim to achieve equity and access to services. We are laser focused on eliminating racial, ethnic disparities in child and family outcomes. Next slide, please. This is a timeline or an overview of the evolution of our infant and early childhood program throughout the years. It's evolved greatly since 1993 when the first pilot program was created. This program was the first in our community to provide consultation on physical, social, emotional, and developmental disabilities for early care and education staff. In 2000, the Special Needs Child Care Program, or the Prevention and Inclusion Program as we know it now, was developed. And this provided a range of supports, including training, technical assistance, equipment to child care providers for children with behavioral, medical, or developmental challenges. Then in 2001, our community developed the first IECMH pilot program, testing the use of the then DC 0-3 diagnostic manual, which was brand new at that time. And so this successful pilot really established the foundation for the IECMH program as we know it now. Next slide. In Cuyahoga County, we have a focus on being responsive and data informed. And so throughout the years, there have been multiple systemic improvements. And so I just want to highlight a few of those because those have been instrumental in ensuring, a really responsive system that can meet the needs of families with young children. In 2012, we hired an IECMH system coordinator. This coordinator helps families navigate the system, which can be complicated and confusing to families who are just in need of help and support. This system coordinator also tracks wait lists. So they look at wait lists in terms of wait lists for services, wait lists for the agency, and can help identify gaps in services and needs. In 2015, we underwent a system expansion, which was very exciting because it increased the number of providers, but also increased a specialized consultation and treatment services, including short-term home-based consultation that allowed for the developmentally appropriate assessment process that Twinkle was outlining earlier. It also a treatment service that was specifically part of this expansion was the attachment and biobehavioral catch-up, or ABC, aimed to support families who were involved in the child welfare system. In 2016, we included the intensive classroom model for the prevention and inclusion program. And this was a more intensive classroom consultation that was specifically requested from educators at the time to support children who were demonstrating challenging behaviors in the preschool classroom. So this was a really targeted technical assistance that remains active to this day. And then most recently in 2021, we underwent another system expansion, again, based on the community's families' needs. We increased the number of providers through generous support of our philanthropic partners. We had CPP training cohort and added an emergency response therapist, which allowed us to be more nimble and quick to respond to families who were in need of services now and were unable to wait. Next slide. So we have a continuum of care here. In addition to the state-funded Whole Child Matters services, we really have two buckets of programming. With Prevention and Inclusion Program, our lead agency is Starting Point, and that's funded at about $1.8 million a year. There are 8 community agencies providing the service, and they serve approximately 1,150 children and families through PIPs. We also have early childhood mental health services. These are services that occur primarily in the home. Our lead agency and co-funders are the Adams Board of Cuyahoga County. There's about $1.4 million available per year, 7 community providers, and 850 children and families served through ECMH services. Next slide. This is a crazy slide, but this is what funding looks like here in Cuyahoga County. They talk about braiding funding. We are weaving the fabric over here. So we are very fortunate to have consistent, sustained funding through local HHS dollars, Health and Human Service Levy dollars. We have direct philanthropic funding, and we also are able to leverage Medicaid reimbursement when appropriate. Next slide, please. Despite the luxury of all this funding, we've been tracking waitlists through our ECMH system coordinator since 2014 at an agency level and also at a state level. And we know that the need for services is great. We have a targeted reach of about 2,000 families a year through the Prevention and Inclusion Program and the home-based early childhood mental health program, as I was mentioning in the last slide. However, we have so many more children aged 0 to 5 in Cuyahoga County who would benefit from promotion prevention programs for early childhood mental health. We know that children have been on a wait list every week since 2014. Current wait lists vary anywhere from 1 to 12 weeks, but there's an average of about 2.5 weeks in this moment in time. Typically, wait lists vary, have a cyclical nature. Typically in spring and summer months, children increase on the wait list because we have children being referred for support during the summer months, but we also have interns leaving positions. Then again, in the fall time, we see another sort of increase on the wait list because kids are back in school or at childcare centers, and so are being referred by our community partners who could benefit from the IECMH supports. Next slide, please. And we know that the root cause of this wait list is the limited workforce capacity. If we do nothing, our system is unable to meet the actual or potential demand for services. In 2019, we had a community planning process to address the acknowledged ECMH workforce issues. We have barriers that are contributing to a chronic wait list and preventing that really responsive and representative system that we know we need to ensure that services are reliably available when and how families need assistance. The pandemic prevented the implementation of the 2019 plan. So in 2023, there was a recognition that things had changed. So we had many philanthropic partners come together to form the Cuyahoga County IECMH Funders Task Force. We also had a very highly skilled workforce consultant, Kirtland Consulting, and an early childhood team to really create a plan that would work to expand and strengthen availability of these services. Over 40 stakeholders were interviewed in this process, including early childhood mental health providers, special needs childcare or PIPS providers, non-ECMH providers, and funders to get to the real root of the issue. Next slide, please. The task force really worked diligently to contextualize the system and agency level barriers. And we found at least 4 different issues preventing a full capacity ECMH workforce. And so a recognition that there is low visibility of IECMH within the behavioral health field. So training is not typically provided in undergraduate or graduate programs. And so myself included, I was focused in trauma-based work and was working at an agency where a supervisor asked me, "Are you interested in early childhood mental health?" I had never been introduced to the concept of IECMH or didactic relationship work. And so to me, you know, it is something very interesting because it's reliant on real local or state funding for training, or the ECMH providers themselves to provide specialized training on working with families with young children in community settings, and the DC 0 to 5 diagnosis. There are also requirements around advanced degrees, and so there's a lot of discussion about what training and level of specialization is needed to have a full continuum of promotion, prevention, and treatment services. Master's degree will support a highly trained workforce to provide those clinical services, but there is some nuance in how to support promotion and prevention. There's also limited sustainable funding for services because of barriers that Twinkle outlined to billing Medicaid, and providers' comfort level or agency ability to be reimbursed for Medicaid for IECMH services. So we're really lucky here to have that sustained local funding, but it's not adequate enough to meet both workforce and service needs. So lastly, there is a real issue with comparatively low wage for IECMH workers. It's a really high stress, high turnover job. IECMH work looks different. So polling from graduates to make, a living wage and concern about home-based or community-based work, is real here in this community. Next slide, please. So just quickly, I will go into more detail and some follow-up questions here, but the 5 strategies that were identified were to increase awareness of the IECMH field, support paid internships, develop career pathways from non-licensed to licensed, and to advocate for Medicaid recognition of the DC 0 to 5, as well as join the Alliance for the Advancement of Infant Mental Health. This project will achieve, we hope, over 120 new IECMH staff entering the field and being retained over the next 3 years. Next slide. Again, it's a comprehensive plan, and we can get into more detail. I'm happy to talk more with anyone else who's interested in joining this tremendous effort to address a really chronic, persistent workforce issue that we know is impacting families with young children. Next slide. That's it for me. Thanks, Caitlin.
Thank you so much, Alyssa. That was really helpful to hear all the work that you've done at the local level. I know you've been really busy behind the scenes, and it was great to see your strategic plan and your outline. Thank you for sharing that with us. We have just a few minutes left, and so I will facilitate a shortened panel discussion. But Dr. Pacito, I would really love to jump back to you for our first panel question to kind of leverage something that you mentioned in your presentation relating to diagnosing young children. So I'm wondering if you would be willing to expand a bit more on diagnosis and stigmatizing labels. A lot of mental health professionals working with infants and young children have differing views on this. And so I wonder if you would be willing to speak to some of those concerns and what a diagnosis can really offer an infant or young child who's in need of mental health services.
Sure. No, I think it's such a good and important question. And I will say, as a clinician, I often shared concerns about overdiagnosing, like normative variations in child behavior. I'm a parent of 3 under 6. I know what normative variations in child behavior can be extremely stressful and disruptive. And so I understand it's a delicate balance there. What I will say is that, so the short answer for why it's important to use the DC 0 to 5 in particular to diagnose infants and young children. Well, there are 2 short answers. One is that usually you cannot provide services without a diagnosis. I think there are a lot of things wrong with the way that our system is set up. And usually, although some of the states that we provide TA to in 0 to 3 have figured out a way to provide some limited services to kiddos without a diagnosis. Happy to talk more with folks offline about that because that's an exciting development. But generally you need a diagnosis to treat behaviors. And I think, so the DC 0 to 5 is really uniquely suited to provide clinical case conceptualization and diagnosis because, yes, it is grounded in scientific knowledge of mental health disorders, just like the DSM or the ICD-10, but it is considers very concretely developmental context and family relationships and what is normal in that child's context. And, you know, what is depression in a 4-year-old looks very different from depression in a 16-year-old or in a 60-year-old. But 4-year-olds can and do experience depressive symptoms. And whether it's depressive symptoms or clinical levels of depression, they can and do experience them. And again, we're not diagnosing the child, we're diagnosing the symptoms. So we're not saying when we use the DC 0 to 5, we assess the whole child, and then we say, hey, your kiddo has some symptoms of depression. Let's think about how to get you services. We're not saying your child is depressed and will be depressed forever and your child is bad or broken. We're saying, hey, good news. We have this tool that has identified these symptoms and we can treat you. Without a tool like the DC 0 to 5, those symptoms aren't going to be treated because the DSM is not going to pick up depressive symptoms in a 4-year-old. And, you know, I know there's a view that, you know, particularly among the we don't want to diagnose children crowd, that kids grow out of these things. And certainly many kids exhibit challenging behaviors or go through tough times that they grow out of. But many children experience real mental health concerns that, much like in adulthood or in adolescence, don't go away without treatment. And so as a whole, I do think it is more important to use a diagnostically sound, developmentally appropriate tool like the DC 0 to 5 to diagnose so that that 4-year-old with depression doesn't turn into that 16-year-old with depression that is much harder to treat than it is at 4 years.
Thank you for that, Dr. Bassito. That's really great insight. Thank you for sharing that. I think that that's an important message for anyone, you know, at any end of the spectrum with this, whether it's someone in the community who wants to learn more about this, or a legislator who has the power to bring the DC 0 to 5 to Ohio. Thank you for that. My next question is for Alyssa. I'm wondering, with all the work that you did at Invest in Children, would you mind speaking to what is important to know about the return on investment when we prioritize IECMH programs and treatment? I'm wondering if you have thoughts about the potential cost of continued inaction.
As an employee of Invest in Children, I have to say thank you for this question. As they say, an ounce of prevention, right? So we know that early identification and intervention are critical during the first 5 years of life. It is a crucial period for brain development, as Alex outlined, acquiring the social emotional skills necessary to succeed in school and in life. So when we are able to support positive relationships and positive environments, we really set that solid social emotional foundation on which all other development can occur. So this is also quantifiable. According to 0 to 3, every dollar that is invested in IECMH services returns about $3.64 back in prevented treatment in later life. And some other interventions like the CPP or child parent psychotherapy have an average return on investment of about $13.82 per child. So these are cost savings that accumulate over time through adolescence, young adulthood, and even show impact on employer costs. So not only does building a strong early childhood system make sense from like a human perspective, because we care for young children and we care for their families, but supporting IECMH and other early intervention services really make good economic sense. It's a really compelling argument. And I think as early childhood providers and professionals, we can be really confident in advocating for investment in early childhood services.
Thank you, Alyssa. It's really good insight. I really appreciate that, and all the work that you've done in Cuyahoga County that I really think can be scaled and used at a statewide lens as well. Twinkle, my last question is for you in the final few minutes that we have here. I'm wondering, from your wealth of experience in diverse practice settings and just all the tenure that you have in this field, you really highlighted in your presentation the importance of hope. And we know that we are up against a lot of systemic challenges and barriers, from diagnosis in the DC 0 to 5 to billing stuff. And Twinkle, I just wonder if you can really shed a light on the direction that Ohio is going from when you started in this field, in this specialty years ago, to where we are today. Can you draw briefly a line of hope for us in the things that you're seeing in the good trends and in the direction that we're going?
I wish I could say that there was a magic wand and we waved it and everything would be okay, but we're not there yet. The important part is there's more conversation, and the words infant mental health are no longer silent. We have a team of people throughout the state who are advocating for more services in this area. We didn't talk about diagnosis and treatment because we were having difficulty even bringing up the words. And so the amount of providers we have has increased. We just need more. We need more pay. The hope is that if we could increase the pay structure, if we could increase the ability to do more evidence-based trainings for free for the providers, that's the hope. That's the goal. Because when we get to a point that there are no wait lists, we know we've done our job. I don't know when that's going to happen, but I know that we have to continue to seek toward that goal. And it's overwhelming sometimes. You can't stop. Even though you think, oh, I can't help them all. If you can help one and then just one more, you're making the difference. So the hope is don't give up. We got this.
Thank you so much, Twinkle. I see a really great question in the Q&A that's asking, can you speak to cultural sensitivity of treatment? In the last couple of minutes here, is there anyone that would be willing to take that on?
So I was actually just responding to that one and the question above it about cultural competence and diversity of workforce in the chat. So I'll just maybe speak to both of those here. To the first comment about kind of general diversity and cultural competence and cultural sensitivity in the mental health field in general. I think we all know it's a big problem. We need both in mental health services for adults and in the IECMH space. We need more care providers who live in the communities where they're providing services, who speak the languages of the families they're providing services to, and just generally look like and live like the folks that they are working with. I think that the good news is that in my personal and professional experience, the IECMH space pays more attention just to context than the broader mental health space does, as a function of having to consider context to understand infants. And so that naturally includes understanding a family context and understanding community and cultural context. And I think because the DC 0 to 5 specifically takes into account culture and community in diagnosing, I think for many infants and young children, those diagnoses are already more culturally informed than many diagnoses for adolescents or adults. Cultural sensitivity of treatments remains a pretty big problem. I think that we need, from like a high top level government funding level, we need more funding for evidence-based treatments that are culturally specific, that are tested and developed in the communities where they're going to be delivered, because we still very much do research on middle class white folks, and then take those treatments that work really well there into communities that are very different and may not work as well. And so we're not prioritizing those children and families, and that needs to change.
Thank you, Dr. Bacido. I really appreciate everyone's participation here in the panel discussion today. Thank you for your questions. I think that it's clear we have a lot of room to grow, but there's also a lot of really great things that are happening. And just by showing up here today, you are being part of that change. So thank you for taking interest in this topic. Thank you to each of our panelists for being here. And that does conclude our webinar. Thank you so much for your time. Take care.